Thank you for joining us this morning for what will be a continued day of insightful discussions as well. My name is Saudamini and I'm from HITAP.
And my name is Chayapat Rashatan. We are pleased to be your Master of Ceremonies of this side meeting titled From Historical Insights to Crystal Balling the Future, Preparing Models for a New Generation of Challenges. It's truly a pleasure to have each and every one of you here today, and we are grateful for this opportunity at PMAC to interact with you both in person and online.
So we asked you already a bit about those two questions, but you can have a look yourself. So what are the results telling us, Chayapat?
Yeah, so it seems like most of us agree that epidemiological modeling have helped us during the past pandemic. But we also may still considering or unsure about what will be its role in the next of our pandemic. But don't worry, we will still have more chance to hear more from our experts who will shed the light into these issues.
So great, Chayapat. What do we have in store for today's session?
Sure. So in the next few hours, we have an exciting lineup for you. We will be reflecting on how modeling was used to address the COVID-19 pandemic. We'll also be discussing potential unforeseeable issues that modeling community may have to address and adapt to. And last but not least, we'll be distilling key messages for the Lancet Commission on strengthening the use of epidemiological modeling of emerging and pandemic infectious diseases.
And how are we going to do that? Stories are a powerful way for us to learn lessons from the past and communicate them with a host of people. And today we are in the company of some of the great storytellers of our time. We'll start with a keynote from one of them and then hear a bit about this commission that Chayapat mentioned before continuing to hear from a diverse set of perspectives from other storytellers, reflecting both on what we've learned or they've learned from the past and then future balling, crystal balling the future.
Yes. So without further ado, let's hear from our first speaker of the day, Professor Gabriel Ling, Executive Director, Charities and Community of the Hong Kong Jockey Club, who will share us what will be a captivating case study on how epi modeling supported decisions during the recent pandemic. Please join me in welcoming Professor Gabriel to the floor.
Or would you like to, like the second question, would you like to go and look into the future? Which one would you like to do?
1 quarter past, 3 quarters future.
One quarter in the past and then 3 quarters into the future. All right. Any other requests? You're like one of my colleagues who asked for 1/3 of this, 1/2 of that. For their meals. Let me just try and do my duty. But I would actually, if one is going to look in the past, you would have to look way back in the past, rewind about 20 years. When you're talking about modeling, everybody now talks about modeling, and most people nowadays who actually have never even read a full paper of modeling go on and then spout, oh, what do you think about AI? AI is very much dependent, especially these large language models, are very much dependent on what you feed it. Hence all the copyright suits, including notably of the New York Times. So I'm not entirely sure that AI has, as of today, a role in modeling. Modeling is actually just simplifying reality and then hopefully identifying some core drivers, not necessarily causal drivers, but core determinants that would allow you to look into a little bit of the future. Or actually at its core, it's not even to look into your crystal ball. It's to test hypotheses when you can't run an experiment in a test tube. So that's really what modeling is about. It isn't about crystal ball gazing. It isn't hocus pocus, and it's definitely not about feeding big garbage data in and getting garbage out the other end, which is what large language models do for you. And that's why ChatGPT is still not perfect. So I would caution anybody who thinks that looking into the future and then saying something about generative AI or some other kind of multimodal modeling suite approach is going to solve the problem. Those people probably have very little experience of using models appropriately, let alone actually generating useful insights from models de novo. So that's my word of caution. But if you actually go back several decades and go back to the time of the HIV pandemic, that was the time when a lot of breakthroughs started, where you would apply insights from the ecological field, where you would apply from natural populations, and you apply those insights to looking at an emergent outbreak. And subsequently, there was a book which was, at least, the definitive text on modeling by Bob May and Roy Anderson and May. They literally wrote it over 10 days in Bellagio, the Rockefeller Center, by Lake Como. Bob May subsequently, of course, became the president of the Royal Society in the UK. Roy Anderson briefly became the rector of Imperial College, following a very distinguished career at Oxford. And he is still somewhat active as a wise old man of modeling. But subsequent to that, plenty of people have then pushed the field forward and moved the field forward. And I think that if you look back, a relatively recent modeling attempt at looking at a potential global outbreak was SARS-1. That's 21 years ago to this day. And that time, there were two models that actually came out, one in Science, one in Nature, one by the group headed by Mark Lipsitch at Harvard, and the other one was a collaborative piece of work between Imperial College and Hong Kong U, based on Singaporean and Hong Kong data respectively. That helped us to sort of explore, and indeed it showed that modeling did and could influence decisions. Although even at that time, a lot of the wise bench scientists, particularly the microbiologists and the pathologists, got a lot of the answers right, even without the help of those models. All right, just based on experience. But since then, if you then go and then look fast forward 6 years, then you got to pan flu, H1N1. But remember, SARS actually started out when people thought that it was an H5 outbreak. Because there were indeed a few cases, human cases, of avian H5, just at around the time that SARS-1 emerged. And there were a couple after it had emerged. So people weren't clear at all what the bug was. And then after SARS, people still, having been scared off, and that's mostly the Western world, having been scared off, but never really had an outbreak except for Toronto, then went into overdrive. It was also the same era when in the US, which still drives much of what happens in science and a lot of the funding, that goes into modeling. And that's also the time when there was the start of the modeling consortium funded by NIAID, which carries on to this day, but in a much, much, much different form. So during those 5 or 6 years between the aftermath of SARS and 2009, there was a lot of effort that was dedicated to pandemic preparedness, but under the guise, especially in the US, of bioterrorism, biosecurity. You'll remember also at that time, there were a couple of actual smallpox deliberate release incidents. So you couldn't get any grants funded in the US without using the umbrella of biosecurity, bioterrorism. And so those years, and if you remember, there was a landmark paper in Nature, 2005, by Neil Ferguson and company, that basically said, if you use the concept of ring vaccination, but then douse it with Tamiflu, you could basically keep any emergent avian influenza in humans under check. That was, of course, wildly optimistic and probably wrong in retrospect. But that's okay. Models are supposed to be disproven as much of science. You only make progress when you disprove something from the time before. So then came 2009. And 2009, it kind of crept up on us. Nobody was entirely sure where it actually started. There is this intense search to this day of where COVID started and how it started. But there wasn't and hadn't been a fraction of the attention of how and where and why it started in 2009, which to me is extremely interesting, mostly about geopolitics and US national politics than science. But as an aside, if you actually plot out the first few hundred cases, documented cases of H1N1 in the US, remember that there was this suspicion, and certainly it was called as such, it was called the Mexican flu for a while, until it got to be a little bit perhaps invidious, if not outright racist, to have called it that. Then people started calling it novel H1N1. But if you actually plot out the first few hundred cases, interestingly, if you go back in time, it very much looked like the map of the old Mexican border, i.e. including present-day Texas, and so on. So if there is any kind of interesting geopolitics, is actually, if you actually map it out, it's old Mexican territory. Now, so if you go to 2009, none of the models mattered. None. Zero. Zilch. Because it spread everywhere before any of the models could have mattered. Nobody applied the dousing with Tamiflu ring approach. No one did. Even vaccines didn't matter. Most of the rich world got vaccines, but most of the rich world threw away 90% of what they procured, including in Hong Kong. I was the deputy health minister then, and I had to go and explain in my legislature why we bought and then had to throw them away. So I think that those were lessons that were not learnt. And that's bad. Most people focused on why Margaret Chan overcalled the 2009 pandemic flu outbreak. And that was probably because she undercalled the previous one. Right? So you will never get it right. And then people, of course, now swing and say why Tedros undercalled COVID at the beginning. Didn't call for masks until May, when it's already swept half of the Western world. WHO still
Right, thank you.
Thank you, Tanya, and thank you for being on time.
at that
perfectly.
time
And
said, look, it's not airborne, it's not airborne, right? So you can never quite get it right. But then if you actually look where it did actually make a difference, and nobody really paid any attention because it didn't affect anybody other than China. That's 2013. That was a close call. And at that time, there was another outbreak of another avian flu species crossing the species barrier, but it was in and around the Shanghai Yangtze River Delta, which subsequently, after a couple of months, spread down to the Pearl River Delta, which is by Hong Kong and Guangdong. That was stopped, age 7 and 9. And at that time, it was very, very definitive that you had to do mass culling. And that's what they did. And those models actually did matter, not because we actually did those models, but it clearly mattered and basically contained it. And then the next time that models were used were not anything to do with controlling emergent outbreaks, but it was more for post-mortem purposes. That's the 2014-15 West Africa Ebola outbreak. A few of the healthcare workers were flown back to their respective countries. Both in the UK, they were treated in the ultra-high level containment unit at the Royal Free in London, and a few were treated in Emory in Atlanta. And there was a huge industry of modelers who tried to help explain what had gone on and how it had happened. And a lot of those were social behavioral insights of how people behaved and how people handled deceased loved ones and hid them, and why and how long they did, and therefore that's how it went on spreading. And then there were some very macro numbers that were projected by a couple of people who really didn't know very much of what they were doing at the Harvard Kennedy School for and on behalf of the National Academy of Medicine-led task force that published this Global Health Security Report. And in fact, a few of the commissioners are here. Other than myself, Peggy Hamburg, who was the US FDA commissioner and president of AAAS, is here, and she was on that commission as well. So if you're interested, you can corner one of us to get more stories from there. And then after that, period of relative calm until COVID. And I think COVID, the first question that you answered as you came in through the door, I think it's not unfair to say that models did matter, but only mattered in places that either had previous sociological imprinting, is what I call it. In fact, I felt so strongly about it that I wrote a paper in PLOS Medicine about it. So these are the places like Hong Kong, Singapore, China, and Canada, to be honest, and also Australia and New Zealand. Or they had a, by and large, science-driven approach to policymaking. But the irony is, the places with the strongest modeling groups didn't follow the science. And let me be provocative and volunteer the US and the UK. Absolute strongest in modeling sciences, without a doubt. Highest intensity of competent, really high quality modeling groups. But neither country really followed what their modelers told them. And the modelers were by and large correct. So how did that happen? Why did that happen? And how can we prevent it from happening again? And that's why I think, and I'm going to conclude my remarks here because I've drone on for long enough, I think that is the whole raison d'etre of this Lancet Commission, which is not so much about trying to preach and to get the rest of the world to learn how to model, but mostly to get people to appreciate what you can and cannot ask of models, but more importantly is how you get decision makers to follow good science, because you can have the best models in the world and people don't listen. So we're a dual task. We have to make sure that on the technical front, that you can tell which is good, which is bad, which is appropriate, which is inappropriate. That is actually the easy part. The very difficult part is how do you get decisions that are grounded in the science that you generate. That bit, most of us have had very little experience. And that bit is the bit that will either lead us to a good outcome or to a very bad outcome. And I think that if people think we should be preparing the next one based on the COVID experience, then we're very, very wrong. Very wrong. Okay? So we should not at all be preconditioned by that availability bias of what just happened. It won't be the same. I can almost guarantee you. How it will be, I don't know. Otherwise, I would be working in hedge funds and would be a very rich man. And incidentally, about storytelling, I have never spoken with more hedge fund managers than I had during COVID. I've spoken with more hedge fund managers and health ministers and prime ministers of more countries than I dare to count during COVID than I would care for the rest of my life put together. So with that, thank you so much. And I look forward to a very rich discussion and learning from you.
Thank you so much, Gabriel. Indeed, one of the great storytellers of our time. You reminded us, as you said, not to give in to recency bias and to really extend our data points and right through the HIV pandemic as well. And bringing us to the present, and also highlighting the geopolitical elements of the response that these kind of crises really instigate, and really making it relevant to our theme today. And then finally, bringing us to what's at stake now in terms of how we use this kind of the evidence or our lessons to then for decision making for the next pandemic as well. So with that, we come to our next section, which Chayapat will introduce us to.
Yes. So now, as we move forward, we are honored to welcome Professor Margit and Associate Professor Vanridhi Israruwachai, the co-chairs of the Lancet Commission on Strengthening the Use of Epidemiological Modeling of Emerging and Pandemic Infectious Diseases. They will introduce us to the Commission's objectives and present the progress so far. So Professor Mark is a professor of vaccine epidemiology and head of Department of Infectious Diseases Epidemiology, and co-director at Global Health Economic Center, London School of Hygiene and Tropical Medicine. And Dr. Vanridhi is the director and senior researcher at the Health Intervention and Technology Assessment Program in Thailand. So please welcome.
Thank you very much for that introduction, and thanks, Gabriel, for that very sobering message. I think you really encapsulated the rationale for why we put together with the Lancet, together with many other partners, this Lancet Commission. Dr. Vanridhi, feel free to join. So what we're going to do together is actually give an overview of what the Lancet Commission is about, just for 15 minutes, because we don't want to actually take the show. We want this show to be about listening to different people as they share with us actually what is really important in modeling, and the translation of modeling into policy. And so what we did, the Lancet Commission has been going on for about a year now, but we have another year to go. So we're somewhere at the middle mark, and I can actually click this forward, right? Brilliant introduction. So towards the end of last year, most of the commissioners were able to meet together in Singapore actually in November, actually to take stock of, well, what has happened so far, what happened with modeling in the COVID pandemic, but also this entire 20-year sweep of, pandemics and emerging infectious threats that we've had over the last 20 years. What has the role of modeling been? What have the limitations, the failures, as well as the successes of modeling? And we reached a conclusion very similar to what Gabriel said, that actually modeling is a tool that can support urgent decision-making in these highly uncertain and rapidly changing situations. I mean, what Gabriel talked about modeling, being able to successfully predict, I wouldn't say predict, but successfully understands the situation and come up with scenarios about the future. I mean, this could actually translate into actual real lives saved if it translates into good evidence-informed policy. But on the other hand, the group of us who are modelers, but also epidemiologists, ethicists, economists, many other people also concluded that actually modeling is a cottage industry compared to many other sources of evidence for decision making, like maybe clinical trials, for instance, or even health technology assessment. Modeling is a cottage industry that needs to quickly mature because it is such a powerful and potentially important tool, but it needs maturity in order to reach that level of being able to really influence policy in the most effective way possible, and also needs a conducive environment, not just from modelers, but also from the wider community, policy makers, scientists, and so forth, in order to reach that level of maturity and effectiveness. So this is roughly where the Commission is going. But this might be actually the sort of very rough roadmap, but we still need to plot the path along the way and determine the final destination. So that's where we really want input from all of you. There's sort of real three streams in this Commission that the Commission has been about. One stream, which actually Gabriel has been chairing, is the policy stream. So really describing different kinds of modeling to policy translation processes. For instance, during the COVID pandemic, we saw different sort of environments and mechanisms to translate modeling into policy in different countries. We saw, some countries having public health agencies conducting modeling, some countries having committees of modelers, other countries having particular academic groups directly interfacing with ministries of health, for instance. Then identifying the key stakeholders, their roles, and then the key principles for bringing that modeling to policy making. There is also a technical stream about the nuts and bolts of the modeling process itself, and really understanding a taxonomy of the different kinds of models that have been used for policy making, how they relate and their advantages and disadvantages, and being able to turn that then into guidelines, very high level guidelines, because we don't really have guidelines in the same way that we do for clinical trials or health economic studies, but having the first sets of guidelines for model development and evaluation. And then really importantly, a communications work stream. So the technical work stream is led by Alex Cook, who'll be speaking later, and the communications work stream by Zulma Coutinova, who's who's a brilliant modeler but isn't here at the moment. Who will really be leading us in developing best practice guidelines for responsible reporting and communicating of the model results to both technical audiences, so other modelers, but also non-technical audiences, policymakers, the general public, who also have the right to know what are these essential inputs into policy. So the group of commissioners, we've got 16 commissioners, as you can see here, and we've deliberately tried, with the strong encouragement of the Lancet as well, to make this as diverse as possible in terms of regions in the world. So there might be regions with historically more capacity in modeling, but we also want to hear from the regions with less capacity in modeling to reach sort of equitable levels of capacity. So capacity strengthening is really a very key part of the commission in terms of organizations and gender, and even from expertise. We had not just modelers, but people representing many other backgrounds as well to be part of this commission. And I'm going to hand over now to Dr. Wanrudi.
Thank you very much, Mark. And to all of you for joining us. So with all those expertise, we certainly will be using different approaches. We'll be meetings among the commissioner, among the working group members and external stakeholders, which we hope from today we'll be able to engage with some of you as well. Now, I'm looking outside and I see the logo for IMAX. And one of the things that movies seem to be doing really well is they like to give you like a sneak peek or a trailer. So here's our sneak peek. What we are trying to do together is propose recommendations. As Professor Gabriel mentioned, we've been talking about this issue quite a bit. So this commission, we actually trying to give some tangible recommendation. One part would be around message to modeling community, where we could suggest things like model that inform policy should follow certain approaches, or modeler should adhere to certain value as well. So those would be something that we hope that we can put together. And at the end, all the recommendation or the standard approaches that we kind of share, it need to have the capacity to be contextualized to different settings. Among decision maker and policy maker, we also would like to have specific recommendation on things that they can specifically support, such as the need to sustain and build modeling capacity. And we'll finish with recommendation specifically on communication strategy. Now, at the end, with all these recommendations, if we were to make it happen, all of us believe that we hope to show that if models have certain characteristics, like they can be timely, trustworthy, then at the end, models can save life. So, and that's going to require quite a big teamwork and all the support from external stakeholders as well to make it possible. So here's our upcoming activities. We are here at PMAC. We hope to be back here again at PMAC next year, where we can share the final product. But at the same time, middle of this year, there'll be a priority conference also right here in Bangkok, Thailand. If anyone interested in joining that, please do let us know. It's our collaboration with the International Society for Priorities in Health. It will be in May. And we hope to have the first complete report for international peer review that will be held in Africa CDC Public Health Conference in November. Okay. And, but please, we don't have to wait to see each other again until next year. If you like to hear more, feel free to visit our commentary, which also have a link to our commission webpage, or you feel free to email us. We certainly would like to hear from all of you. Okay, so I think that wrap up our section. We'll pass it back to the MC.
Do we want to take any questions? Oh, yeah.
Thank you so much.
Thank you so much, Professor Markjit and Dr. Vanrudi, for sharing us these developments. And we also look forward to seeing more from the Commission.
And with that, we'll now turn to Professor Thumbi Mwangi to take us on to the land, to continue the journey into the land of stories with a diverse set of perspectives. Professor Thumbi is the co-director of the Center for Epidemiological Modeling and Analysis at the University of Nairobi in Kenya. Please welcome Professor Thumbi to the floor.
A very good morning to you. I like and I love Thailand, particularly because of food. In fact, the very first time I came, I loved the food so much that when on my way back, I bought a Thai cooking book. And I took it to my wife to explain to her how lovely the food was here. It took a whole year before we could make any Thai food. And in fact, the reason we made Thai food is because the next mission I was coming, I came along with her. And we really enjoyed the street food. It might be that we make recommendations as modelers, and sometimes the people supposed to follow, they don't fully understand how nice the Thai food is. And some of the reflections we have here are about bringing it home for the people that are supposed to use or make use of models. So this morning, we have a session about stories, and we have 4 fantastic speakers who are going to give us very short keynote speeches about models and early response, isolation, human behavior. We'll have someone talk about models and high-risk populations, taking the example of yellow fever. We have fantastic speaker talking about the role of community engagement during the pandemic. And finally, about money. How to fund pandemics, response to pandemics, and preparedness and prevention. And she'll be speaking to us about the role of modeling in early response, isolation, and reducing the spread of infection. Please come up.
First of all, thank you. Thank you for having me here. I had the privilege to come to Thailand many times. The first time was responding to the HIV epidemic in the 1990s. So when Gabriel was talking about the modeling work, I was reflecting my own roles in responding to epidemics and pandemics. Actually, I was in Beijing in 2003 responding to the first SARS, and then I was living in Beijing for the COVID-19. And I also responded, into those Ebola outbreaks and also H1N1, because I spent most of my career and public health career actually at US CDC. I was trained as, we call this disease detectives, ES officer, epidemic intelligence service officer. So this gave me a great pleasure to talk about the topic I want to focus on, the modeling. Personally, I also invested my own time in learning about modeling. I spent 2 weeks in the early days when modeling becoming industry in Imperial College to learn about modeling. So if you ask me to do the code, probably I don't know how to do it. But today I think my story is about what I wrote in Lancet, also the global health paper, early actions. I asked back in 2000, and after reflecting what we have learned from COVID, one time I asked the ChatGPT, what do we have learned about COVID? ChatGPT gave me 3 main messages. One of those is early action. I think modeling is going to give us a really good understanding, at least a piece of it, to tell you what the consequences are going to be like if you delay actions. In the early phase of responding to epidemics, you don't really have a lot of interventions or tools at your hand. So isolation will be one of those. But isolation is not like a cutting ribbons in front of a brand new hospital. It's totally unpopular. So modeling is, tell the decision maker about, this is the potential consequences if you delay response actions, put people in isolation, things like that. But other times, if you standing in the politicians or decision makers' shoes, they have many stakeholders' interests in mind. One of those is that they are, for example, in a democratic country, the interest of voting, their voting base for decision makers at the very top. So I want to, using that context, to make 3 points here. One is that, for modeling work, it's not about how sophisticated your model is. It's a technical as well as a political decisions to be made. It's not how great, right your model. It's not just about that. It's how to use the right and grow the right model and the right making the right decision. So I think that's the most important thing to do. But things like how to communicate the decision makers and the general public even about, somebody mentioned the visualization. I think that's a very good tool. Not only the numbers, the inputs, but also the visualize what the consequences might, different scenarios. I think that is very important part of modeling work. I don't think many modelers have that muscle yet. I think we have to build that type of thinking and that type of muscle for the modelers to really convey the message to the other side of the table, and to help drive the message about taking early actions. The second point I want to make is that again, at the beginning, there's really not many. If you want to take early actions, isolation is one of the early isolations that we always can take, but it's also one of those intensely unpopular actions. So think about who are going to be the people most likely impacted by this type of interventions, and help those population prepared, understand. And so I think some of my speakers this morning going to talk about engagement with the community. I think that's also, if you drive through most unpopular interventions involving the general public, in general the community, I think that is such like isolation. That should be you should think about all mapping that out and how to go one step, engage as many people as possible along with the decision makers with your data. The last point I want to make is that in a typical managing projects or management tool called a RACI, right? RACI. I think in modeling, I was thinking, that's my, just sitting there thinking about this, how to do this. I think maybe we do the backward of RACI. You inform think about who you need to inform with your data and your conclusion and your recommendation, and who you should consult it widely about. I think sometimes Gabriel give I don't know, this our professional understanding. We feel like we are the most informed people because we have the data. But if we behave like we are superior, then, the people we need to inform and consult it. And that's the quick way to not buy in. And, people not going to buy you a solution. And again, we are thinking about who is accountable on, making decisions, and who's, so that's the A, right? The last one, who's going to be taking the action to implement it in the field. So again, I responded to the outbreaks in the trenches, and coming to Beijing, responding to SARS, all that. So that kind of my personal experience and my limited understanding, and my teachers at Imperial College taught me well, but I don't know how to do the coding anymore. So my final point is still here. So I see this take a community, and I think Professor Mark Jett already mentioned that take a lot of people is going to involve in the community to make the modeling work important. Not only important, use it for making right decisions. I'm very, very convinced, and over many years of professional, experience responding to outbreaks and pandemics, epidemics, pandemics. I think modeling is really, really helpful. It's really, really useful. We want to. I think we already travel a long distance to build this community, to build this maturity. It's still maturing, but in my opinion, the next phase is about creating the dialogue with the people who use it as the most effectively as possible. So thank you for inviting me here, and it's really nice to meet my old friends, including Gabriel and Professor Mark Jett. Thank you.
So thank you for those reflections. And I take it about the RACI and starting it from the backwards, that we focus on who is to be informed and make sure that you can consult widely. I think that's such an important way to think about it, and many thanks for those reflections. Next we have Tim, who is the head of Unit of High Impact Events in the Epidemic and Pandemic Preparedness Prevention Department of World Health Organization program. Tim has a lot of experience and he's been a technical officer in the yellow fever program, which coordinated an initiative funded by Gavi Alliance to provide more than 40 million doses of vaccine to most at-risk populations. In 2008, Tim joined the WHO's global influenza program and took part in the global response work to the first influenza pandemic of the 21st century. And from 2014-2017, he was a unit leader for knowledge management, evidence, and research for policy making at the World Health Organization Regional Office for Europe, based in Copenhagen in Denmark. So Tim will allow you to come and give us the case study on the use of modeling as decision aid to prioritize at-risk populations for preventative vaccination against yellow fever. Please welcome.
No, thank you. Very pleasure for me to be here with you to share with you a personal experience, how we use something that we can say is some form of a model or management model to help decision making. And I think my story evolves around how we bring decision makers on board to help understand and buy into a model, and then take a joint decision around how we're moving forward with a public health decision. I'm using experience we used about 15 years ago in Burkina Faso. So just to give you context, so yellow fever is a vector-borne disease. So you need the Aedes aegypti mosquito, to transmit yellow fever one person to another. There is a very effective vaccination against yellow fever. Basically, one shot protects you for life. Since the 1960s, we have this vaccine. And during that time, a lot of mass vaccination campaigns were conducted in those areas that are very conducive to yellow fever outbreaks. In this case, sub-Saharan Africa. So in the 1960s, most population in sub-Saharan Africa were vaccinated. And basically, you didn't see yellow fever outbreaks for many decades. But then in the 1980s and 90s, we have upsurge of yellow fever outbreak because EPI vaccination was not consistently done. You had more and more cohorts of children accumulating vulnerability towards yellow fever. So basically, in the 80s and 90s, you had a whole new susceptible population in sub-Saharan Africa. You saw more outbreaks. So the goal was, how do we, again, reduce that risk of the emergence of yellow fever outbreaks through vaccination. So beginning of the 2000 years, the Gavi Alliance supported a yellow fever initiative, providing funding that would allow the vaccination of 40 million adults. Plus, of course, continuing the EPI vaccination. So our goal was, you have about 12 countries in sub-Saharan Africa which were very vulnerable towards yellow fever. These comprise about 300 million people, but you only had 40 million vaccine. So how do you prioritize those to be vaccinated to reduce the risk of yellow fever outbreaks? So this was the goal of the initiative, and starting with one of the first countries in Burkina Faso is, how do we make informed decision about who to prioritize for vaccination to reach our goal of reducing yellow fever outbreaks, and using different assumptions there to go about. So with that in mind, we thought about understanding really the multiple factors that can cause, especially an urban outbreak of yellow fevers. There are different risk factors. We identified, through our work, 6 risk factors where we were able to collect data. Maybe there are other risk factors, but for these risk factors, we knew we could collect data for all 12 countries up to the district level. And just, explaining 2 of these risk factors. One, of course, is the ecological situation in the country where the Aedes mosquito can exist based on the climate, rain conditions. And so that would be one risk factor to identify where Aedes aegypti mosquito can live and prosper. A second risk factor was looking historically where outbreaks has appeared over a 40-year period. So assumption is, if there was an outbreak before, a case, then there's also likely that something that this area is also under risk to have a resurgence of an outbreak. So these are only 2 of the 6 risk factors we identified, but at least I wanted to showcase at least, how we collected data up to the district level for each of these countries. And the model, we applied was very simple. We said vulnerability is a function of the susceptibility and the exposure to the risk factors. And based on this, we established susceptibility is basically, the absence of vaccination. So if you have at least 60% vaccination rate in a given population, you have a kind of herd immunity against yellow fever, which would then, say this district or this group of population in this area is mostly protected against a yellow fever outbreak. The tricky part was now on the exposure. I explained before, we have 6 risk factors. So how do you integrate, a dimension of 6 dimensions into a model to explain then around, which risk factor is more important than the others? And we, we're thinking about, different options on how to aggregate it. And I will explain it a bit later. But since we have then expected this model basically on susceptibility exposure, we could identify different risk profiles. So basically, if you have high susceptibility, so meaning low vaccination rate and high exposure, probably these districts are more vulnerable and should be vaccinated. Whereas if you have, a high vaccination rate, meaning low susceptibility and low exposure, maybe these districts have a lesser priority to be vaccinated. So that's, our model that we were establishing to explain to the policymakers. And then on the right side, then, basically that's then the model. You can plot the different districts of a country against this model and then identify maybe which district might be at higher risk to be prioritized for the limited amount of vaccine that could be, that were part of this initiative. So the key point was now to synthesize the 6 risk factors, and we used something that was called multiple component analysis. And basically that was decided to be superior than just, the weighting of the different risk factors and then aggregate them in a numerical way. But when we use this kind of model, and using the example of Burkina Faso, this where, where we were able then to plot the, I think 36 districts in the country against this model, and, where we're emerging these kind of clusters of countries. And the second step, and this is my lessons learned from this whole process, is to really, you establish a model, you try to explain, but how do you get consensus in a country to come to a final decision? So this is where we try to separate 2 elements of this. The first step was really this evidence-informed, science-driven approach to bring the data together and synthesize it and present it. But then the second, and this was the most important step, is to build a consensus building in the countries, to really bring the different stakeholders together on the same page to drive decision. So it was really important to bring in a 2-day workshop the people in the country together, including civil society, who also need to explain to their constituents, how these decisions were made, to really understand, what was going on and how we were using models to drive a decision. The second step in this part is also bring everybody on the same page, explaining what you're doing. And here the lessons learned is, in mathematical modeling, there's always a black box. Now, I'm not a mathematician. Most people in this group, except our 2 experts we invited, understood actually what was done under multiple component analysis. So there's always this element of a black box. But it was really important that you at least, have that process of explaining the black box to everybody in the country that will be taking this decision. My takeaway was, in these 2 days, there was, the approachment of understanding the black box. But I'm sure that people who went out of this workshop could not explain to the next person what this black box was. So at least everybody had a notion of understanding, or at least a notion of, we all don't maybe understand the black box, but we at least have that process of involving and making this understood. The second element, and that was really important to decision makers, was that it is a decision aid tool, but there are sometimes certain elements, the black box, the model cannot capture, and we need to leave room for that discussion. For example, during that discussion, there was the argument about one district that was not put into the risk area for vaccination. But then the explanation and discussion in the consensus workshop was, but we know that this district is a trade hub where several people from different districts, also from those at higher risk, come to trade and then go back to their risk areas. And this was then also an opportunity then for the country then to say, even if that model did not show this district at high risk, but from our discussion and our local knowledge we have about our country and our district, we think, that this, should be also go under the risk area for vaccination, because the risk factors that you have captured are not captured in our local context and the knowledge we have in our country. And through this consensus building workshop, you have that opportunity then to define some districts then to put into the vaccination campaign because of the local knowledge that was integrated in during the consensus building workshop. And I think that was also a very important lessons learned when using this kind of models to allow local context to have, the influence in the final decision and consider this as an important element of the whole journey of taking that joint decision in a country. And I stop here, with that example just to illustrate, this process of bringing decision makers on board without, a fully understanding of the entire modeling process that is happening. Thank you.
Very interesting. And I like the idea about explaining the black box. I hope that, I think like AI is even a blacker box. Maybe our job is much easier to explain how things are happening within our models. But many thanks for that very nice presentation. We have that presenter. All these presenters are going to have a chance to sit here to answer questions. So let's wait for that. So we have Dr. Vivian Tatiana Camacho, who will be speaking about community engagement and pandemic responses. She is joining us online. Dr. Vivian Tatiana is the National Director of Ancestral Traditional Medicine within the Vice Ministry of Ancestral Traditional Medicine of the Ministry of Health of the state of Bolivia, plurinational state of Bolivia. She's also a high-level commissioner for the Alma Ata 40 years in the Americas region for the Pan-American Health Organization. She has extensive experience in the health sector and has worked as the coordinator of health for the Bolivia peoples, represented the Andean region, the Latin American coordination within the World Movement for People's Health, and promoter of respectful birth and ancestral midwifery. As an indigenous communicator and a member of the Red del Abya de Comunicación Indígena, which is maybe communication indigenous, in my interpretation, Dr. Machos is committed to promoting ancestral knowledge of indigenous people as a specialist surgeon in the interculturality and health. So welcome you, Dr. Camacho, to give your presentation. Many thanks.
Thank you so much. Big hugs from Bolivia. Now it's about to be midnight here in Bolivia, and I'm so glad to be participating with you, even though it is in virtual session. And I'm glad that we can share our experiences, our views. We can share the knowledge that we have in looking for the good of our people. So as a part of the health ministry, I was listening to my colleagues in the first moment of the session. And now I belong to the group of the decision makers, but also I am part of many research teams in different levels in Latin America and in the Americas region. And we are promoting health as a human right, and we are promoting health systems that had to do with taking care of life in an integral way. We need to remember Alma Ata Declaration more than 40 years ago. Alma Ata Declaration called us to work with intersectorality. I mean, different ministers working together, the water minister, the land minister, the food production minister, different other ones, education and health together. So we need to gain back again that strength for our people if we want to make integral health systems going on. And also we need to talk about interculturality, which has to do with respecting our ancestral wisdom, our ancestral roots. I belong to the Quechua nation. My mother language is Quechua. So let me greet you. Sumaq p'unchay kachun tukuykunapa hatunapay kuytukuy gangyunapa haga Thailandia llaqtamanta, which means have a beautiful day over there in Thailand. We need to remember that when we talk about health, it has to do with this vision beyond merchandise, beyond the market, because we have seen during the pandemic of COVID-19 how health has become another merchandise, very sad for us, because if we are doctors, if we have studied medicine, it's because we want to take care of our people. So when we are engaged in policy making, for the most humble, in most people, most vulnerable situations, we need to address social justice. Otherwise, we won't have health systems separated. We are not able to put ourselves inside balloons. So we need to make it all together for all together. That's why we are struggling for health systems, public health systems that respond to the necessity of the people. And it has to do with the accountability of how our human condition have going through history, as this session says, from historical insights, looking to the future. For us, we have a beautiful word in Quechua, ñaupa. Ñaupa is what is beyond, behind me. So ñaupa. So what is behind me is the past, but ñawi is my eyes to see the future. So if I want to see the future with good response, with proper answers for the next challenge, I need to look to the past to learn. So it is an ancestral wisdom that has kept us alive as indigenous communities. So we need to remember again for these new generations and this new challenge to come that had to do that, and now we need to look back to our ancestral wisdom to face this new challenge that have to do with the climate change situations that will be worse and worse, but also it has to do with facing social situations like war in the world. So we need to face this in the most wide vision, wide mind, open heart, open mind, brilliant mind with intelligence. We call it in Quechua, it has to do with your mind, with your heart, and with your hands. So with the clarity of your mind and the clarity of your heart, you need to make things right with your hands. So it has to do with the coherence, even though we have wonderful scientists researching, but if we forget the most vulnerable, so what are we doing things for? That's why we look to health as a human right. And as a human right, it has to do also with dignity and solidarity and reciprocity, which are human values based on communities. And during COVID-19 pandemic, I was part of the Latin American group that we faced as indigenous region, with some Latin America and Caribbean organizations. So I took the testimony of many people in different indigenous communities, organized communities that defended themselves to take care of themselves with ancestral wisdom, with ancestral land organization, with taking care of water, taking care of food, with herbal remedies, with spirituality. So we address human diversity, cultural diversity to take care of biodiversity. And it has to do with popular health back inside the hands of the people. And it has to do with popular power. So people organized can resist whatever comes in front of them. And we need to address this because we are millions that have survived COVID pandemic, even though we wouldn't have any other answer from Western modern medicine. And it has to do also with community radios that helped us promoting what we are talking about, the defense of land, defense of water, defense of food. And it has to do with taking care of Mother Earth. That's why we have the law of Mother Earth, we have the law of traditional medicine here in Bolivia, and also we have the program of interculturality and community level. And I need to remember that this August 2023, I was participating in the first World Summit on Traditional Medicine called by World Health Organization, which shows that more than 140 countries, we are working with our ancestral medicine as a part of the health systems. So we need to address this together. And also, as Alma Ata called us 40 years before, we need to remember that we are working all together to build together healthy systems. And this togetherness means that we need to address not only our differences, but especially the respect beyond cultures, beyond differences. We need to address what we have to learn from each other, from different situations that we have faced in different places in the world. So in this exchange of cases, I want to share with you what happened here in Bolivia. We have even our law of traditional medicine, and we have done documents to promote our ancestral medicine, our ancestral healing herbs, our ancestral traditions, and we are going on with it. So I know time is very short, but also I want to share with you that we are organized in many, many countries calling for people that want to share their tools, the popular health tools and knowledge to promote health promotion. Is not only the extension and the selling of the different products from Western medicine, which is part of the market-based ideas. Health promotion for us is the respect of our land, the respect of our people, our ancestral wisdom, the respect for the right to food, right to water, the right to education. So it has to do to respect that we all belong together, even we are in different colors, in different places of Mother Earth, which means this beautiful flag called Wipala, that we all belong to Mother Earth, that we all belong together. And even though if the global north have some answers that would not share with the global south, none of us will make it. That's why we are calling for internationalism and solidarity. So a peaceful world is a healthy world. Thank you so much. Big, big hugs from Bolivia.
Many thanks, Dr. Tiana. Beyond the merchandise, which is, I captured that. And many thanks for keeping time, but also staying on past midnight to help improve the human condition, which is great. Thank you. We have a final speaker for this morning before our tea break, Dr. Priya Basu, who will be talking about closing the financial gap for the pandemic preparedness and prevention. Dr. Priya was appointed as inaugural executive head of the Pandemic Fund at the World Bank in September 2022. During the pandemic, she led the multilateral leaders task force on COVID-19 to address key bottlenecks in vaccine access and delivery, as well as the bank's engagement on pandemic prevention, preparedness, and response to G20 and G7, coordinating across finance and health. She also led the development of the Pandemic Fund, working with a large group of donors and development partners, the World Health Organization and other stakeholders, including international agencies, philanthropies, private sector, and civil society, mobilizing political and financial support to establish the fund in record time with an initial seed capital of $2 billion. Dr. Priya, please come. We want to hear all about the money.
Well, thank you so much, and it's a pleasure to be here with all of you in the beautiful city of Bangkok. And I too love Thailand, and Thai food really is amazing. So you've heard from many different speakers this morning. I'm going to talk about the financing gap and how we're working towards closing it. In the wake of COVID-19, the international community came together at record speed to establish the Pandemic Fund with leadership from the United States, the European Union, championed by Indonesia under its G20 presidency, and bringing together countries from the global north and the global south to put this together. And this was a recognition of the fact that despite decades of pandemics, centuries of pandemics, the world kept falling into cycles of panic, followed by neglect, and then panic again and neglect. And really there was no financing mechanism to deal with investing in those important areas that you need to invest in during peacetime, so to speak, so that the world is ready for the next war. And it's not a question of if, it's a question of when that next pandemic will hit us. So the Pandemic Fund is seen as an innovative addition to the global health financing toolkit. It's the first of its kind multilateral financing platform that's dedicated to making investments in pandemic prevention, preparedness, and response activities in low and middle income countries between pandemics. But we also know that at any point in time, there are hundreds of epidemics, hundreds of outbreaks that have the potential of becoming a pandemic. And the modeling community, of course, is actively engaged in looking at those. So really, it's not a question of wartime, peacetime. It's a question of getting epidemic-ready health systems in developing countries. That's what the Pandemic Fund is about. It's investing now so that health systems are ready to be able to deal with the next outbreak that has the potential of spreading across borders. It's really about investing in health workforce, including community health workers, but also field epidemiologists, laboratory technicians, frontline workers, doctors, nurses, everyone that's involved in being able to detect and contain outbreaks. It's about having laboratories that can rapidly scale up testing when the need arises. It's about surveillance capacity. It's about data. It's about building, collecting, organizing, and transmitting that and sharing that data that helps us to detect and contain the next outbreak. And also it's very much about looking at these things, looking at data in particular, looking at surveillance in particular from a One Health perspective, recognizing that animal health and human health are really closely intertwined. So it's not just a question of being able to detect viruses that emerge in humans. It's also a question of detecting viruses that emerge in livestock, in wildlife, that have the potential of being transmitted from animals to human beings. So the Pandemic Fund is doing things differently. Why? Because we have a governance that's based on equity and inclusion. We have a board that balances the voices of the global north and of the global south, that has civil society in it, that has health ministries and finance ministries, that brings science to inform what the Pandemic Fund's priorities are and should be. We have the flexibility to work through a variety of organizations complementing their efforts. So we don't make direct investments in developing countries or regional bodies. We always work with existing organizations like the Multilateral Development Banks, the World Health Organization, UNICEF, Food and Agricultural Organization, Global Fund, Gavi, CEPI. Those are our implementing entity partners. We draw on co-financing from them. So we provide grants, but we say for every dollar of grant financing, you please also bring your own financing so that the whole becomes larger than the sum of its parts. We promote coordination amongst these various actors on the ground, recognizing that the global health space is pretty siloed and disease specific, whereas pandemic prevention preparedness requires actors to work together, looking at sort of integrated health systems on the ground. And also, we work to incentivize the countries receiving our funds to also put in their own levels of effort in terms of financing, but also policy commitments to ensure that whatever we do is sustained over time, because these are not one-off investments that we need to make. These are investments that we need to make continuously to make sure that health systems have that capacity to be able to respond to outbreaks. And finally, we have a very strong focus on evidence-based decision-making, and that's where data, modeling, all of this comes into play. What makes us impactful at the Pandemic Fund is our collaboration with governments, with the WHO, with other UN organizations, with multilateral development banks, global health initiatives, philanthropies, civil society, and very importantly, academia, many of whom are represented here in this room today. So the Pandemic Fund, as our moderator mentioned, came together very quickly to deliver financing. It's a great example of what we can do when we work together, breaking silos towards a common goal. In less than 1 year, we were able to raise $2 billion in seed capital, thanks to generous contributions from G20 countries and beyond. We already awarded our first round of financing last July to projects that will strengthen capacity within and across borders in the areas of early warning systems, surveillance, laboratories, and health workforce strengthening. Our projects cover, this first round of projects cover all geographic regions. 75% of the grant funding went to low and lower middle income countries. Over 30% went to sub-Saharan African countries. These are all multi-sectoral projects that take One Health approaches, all of government, all of society approaches, actually. They bring coordination amongst various partners, and they also bring cross-country collaboration, particularly in areas like data sharing and building regional lab networks. And now we've announced our second round of funding last December, which also focuses on these areas of early warning system, surveillance, and laboratories and health workforce. So what we've achieved so far, it's been quite impressive, if I may say so, but we're falling short of where we need to be. Our first call for proposals last year generated 8 times as much as what we had in our financing envelope. So we say it was 8 times oversubscribed. We had requests from 133 countries for projects, low and middle income countries, for projects to help strengthen their pandemic prevention preparedness and response. And as we were developing the Pandemic Fund, the World Bank, together with the World Health Organization, prepared an estimate of what the financing needs and gaps are, and drawing on other reports as well that had been prepared in the wake of COVID. And we estimated that the world needs about $10 billion per year in additional international financing over the next 5 years to fill those gaps in pandemic prevention, preparedness, and response. And those need to be accompanied by about $20 billion from the countries themselves in domestic financing. So the gap we estimated was that over the next 5 years, we need to put in about $30 billion per year of additional international and domestic financing in developing countries to fill the gaps. But you contrast that with the trillions of dollars that the world lost in the wake of COVID, not to mention, the lives that were lost, then, that investment that's needed is tiny in proportion to what would happen if we don't invest. So right now, and particularly given all the predictions around the risk of pandemics. And there was a study that I was looking at just the other day that said that there's more than a 50% chance that another COVID-like pandemic could hit us in the next 20 to 25 years. And these risks are exacerbated by climate change, by changes in biodiversity, by deforestation, changes in land use patterns, water shortages, all of which are sort of resulting in animal migration and putting animals in closer contact with humans. And given that many of the pandemics of our time have been zoonotic, these kinds of things are exacerbating the risk of the next pandemic happening. So my big message is that what we need to invest, yes, it's daunting, but it's tiny in proportion to what would happen if we do not invest now in pandemic prevention, preparedness, and response. So that is the work of the Pandemic Fund. To fulfill our promise of helping developing countries build resilience to future pandemics, we urgently are seeking more resources. So we are fundraising, and we also believe that very strong partnerships are needed around the projects that we support. And those partnerships must include scientists, academics, they must include financiers, the private sector, global health institutions, and very importantly, communities. Because my friend Mike Ryan at the WHO very often says these pandemics begin and end in communities. So this really is the moment to scale up efforts, to get the world prepared for the next pandemic, but also keeping in sight that right now, as I speak, there are a lot of disease outbreaks, particularly in developing countries, that can benefit from the investments that funds like the Pandemic Fund make, and that can benefit from work of the scientific community, that really helps us to be able to quickly detect and contain outbreaks from becoming pandemics. So thank you very much for your attention.
To continue the conversation, we'd like to ask Professor Thumbi to come to the stage and also steer this conversation. Over to you, Professor.
Thank you. I'll invite Mark as well to join us. So we had a very interesting storytelling session earlier this morning. And we have a few minutes, about 25 minutes, to dive a little deeper into what all of you are doing with your organizations. And then we'll allow the audience to also maybe have a question or two. So I'd like to start by making a hypothesis that your organizations used modeling or use modeling. So then the question I have for you is, what are some of the challenges from the Bill and Melinda Gates Foundation that you faced as your organization during the pandemic in the use of effective modeling to answer policy, or how to translate it into policy? So we'll start with you, and then we can go to World Health Organization and the Pandemic Fund.
Yeah, I think I have two issues. I think I see over the years. One is quality, data quality. I often joke that my standard for quality. I work in U.S. CDC. We have a pretty clear trained as epidemiologists. We have our desires for what type of about the data quality. But in real world, your wish is your wish, but what do you have? What do you have? So that's just one challenge. Another thing is about the setting. I think all kind of modeling today, I think Jed mentioned there's a different type of modeling fits, for different type of questions. I think it's that, as a medically trained doctor, you don't want me, I'm an internist. You don't want me to operate on your kids, right? So I have my limitations, even though I have this wonderful tool, modeling work, but it's true said that what particular settings or areas that can be useful. Different models can be used for different settings or answer different questions. I think that type of understanding is still lacking in the general, decision making, or even the community. Say, why you don't just give me a model? You're a model. You just give me the answer. But I'm an internist. I cannot do the operation. So that kind of understanding that the limits or the boundaries of your modeling work, I think is important. I just want to share this too.
Okay. Tim? Yeah,
I was working.
I think it's similar, to what we heard. I think from our perspective, one of the key or two key issues are the interoperability of systems and then the standardization of data collections. We have so many systems of data collection, and these systems are not talking to each other, are not connected. If you take, disease surveillance systems, not integrated into a laboratory data collection, when you have your case count, not connected to health information systems like workforce determination per country. So how to make the different data collections talking to each other has been a key challenge when you want to do integrated analysis around these different information streams and have like a simple dashboard to have all the information in one place. They don't exist necessarily at the beginning of the pandemic. I think these are some of the key issues that we find as challenging. Next thing comes also around data standardization. As WHO, we are collecting data from 194 countries, but having this standardized in a way requires a lot of manual data cleaning, manual really checking and cross-referencing and going back and asking for clarification. And these are the most two common challenges we see in every emergency, and especially when it comes to a pandemic when all countries are affected and you need to do this kind of data collection.
Okay, thank you, Chim. Any words?
Yes, I mean, I would just build on what's already been said. I think it's data is absolutely critical, and I think all of us faced problems in accessing the data that we needed. Just to unpack that a bit, I mean, there's the data on disease, there's the data on disease progression and disease spread, and how that's evolving and how that evolved in the course of the pandemic. There was also kind of one other piece where better data would have been very helpful, and that was about vaccines. There was a lot of opaqueness around vaccine availability, vaccine schedules, when those vaccines were going to arrive, where. So that was another big piece that we had to kind of quickly work on in the course of the pandemic. While the pandemic was progressing, together with the IMF, the World Health Organization, and the World Trade Organization, the World Bank led this multilateral task force on COVID-19. And one of the big pieces there was putting together a database on vaccines. So I think we've learned a lot from COVID-19. I think one challenge going forward is keeping those investments somehow going, keeping that ever warm capacity, and already I think a lot of progress that was made on the data collection, data mining side. I was reading the other day, those investments are kind of falling through the cracks now. So, we might be again at square one on these areas when the next crisis hits us. So that's kind of on my mind.
Okay, I'll have a follow-up question for the three of you. What you're doing differently as your organizations, now that you've been able to identify these one or two key challenges. But before then, I know, Mark, you wear the hat of leading the Lancet Commission, but also you're an academic. So what are the challenges from your point of view as a modeler that you experienced in translating some of your insights into policy?
That's a great question. Actually, before I answer that, this was a really interesting discussion. I have a kind of follow-up question, because all of you talked about data, and I think that's such an important need for modelers. And I remember when there's a crisis, like at the beginning of the COVID pandemic, I remember the first few months, there was a huge scramble for data to understand the pandemic. And it wasn't that actually countries were actually very open to sharing. It wasn't they didn't want to share, but it was more that systems weren't prepared. So modelers were going to, people were sharing on Twitter or downloading news articles, translating them from, different languages back to English, or, getting line lists being sent as Excel sheets around the world. And it felt like this was really not the way data should be shared. Or looking on Wikipedia, or Johns Hopkins put out a sort of like dashboard eventually, but maybe it shouldn't be up to, newspapers or individual local public health departments to put them out and then we all scramble to find them. Is there any chance of some sort of global mechanism that can quickly capture this data as soon as an emergency happens and put them out in a standard official format? That's a question, but well, maybe that's one of the challenges that modelers faced at the beginning of the pandemic. And then in terms of translation to policy, I think maybe again, in different countries, there was a sort of different systems. In some countries, there's a very standardized, okay, when a pandemic happens, here's the standard operating protocol. The modelers will get together in this way. They will input into policy in this way. In others, I think there was a lot of, things had to be invented on the fly, and then in sort of like not in inverted commas wartime, you don't want to be creating structures. And there were challenges because, there were also various groups which sort of claimed to be modeling groups because they had some analytical capacity, but they were really had no experience in epidemiological modeling. But we said, we've had some time when we've put together this modeler, and the decision makers sometimes didn't know, should we trust this model? And so maybe there needed to be some protocol before the pandemic happened to say, okay, when the crisis happened, here's how we're going to work. This is the standard of modeling that we need. We need people with a track record and so forth. So maybe that's another challenge. But yeah, thanks for the question. And whether any of you have any insight about any of these things?
Yeah, I think in terms of, what foundation, Gates Foundation, in responding COVID, for example, we are realizing the importance of epidemiological modeling, and we put a money call for proposals. Basically the modeling groups responded to our call, and they become a consortium, and so we support that consortium. But that's just a starting. How to maintain? You mentioned there's a cottage industry, and the industry. I think my prediction is that if you're treating modeling as an industry, that's going to be a market failure, because who's going to be buying your products? So who's going to investing into? So I'm thinking about mechanism to maintain the ever warm, modeling efforts. And yeah, I think that's a mechanism. Like for vaccines, we have a Gavi. For prepare vaccine early research, we have CEPI. But for modeling, we haven't come up with some sustainable organization that is just, for their their fundamental work is going to be modeling. So again, I think it should be on what is the nature of it. Is industry, then how you deal with market failure. If it's an NGO or governmental, then how you organize the mechanism. I want to push back a little bit about, entitled modelers, because, consortium in China, I said we have 6 groups that join us as a consortium, and then one of the best modeler group actually was not a traditional modeler. They're mathematicians from Peking University. So they are not doing, before COVID, they never touched public health and never engaged in infectious disease work. But when the moment came, then all hands on deck. They volunteered that, they responded to the proposal. They become one of the very effective modeling scientists, I guess. And then they did a good work.
Tell me 2 points, and then reflect on your question to me. I think first, we have to be very careful what we ask governments to share data on, because we're also asking a lot. Actually, we have a lot of data. Actually, most of it we don't use. So there's also sometimes an overburden on what we're asking for data to be shared. If decision makers not seeing that we make systematic use of this data. So I think that's one element I captured from past experience of emergencies. The second one is, if you go back to the 2014-16 West Africa Ebola outbreak, we had a situation there that there was research ongoing and the data was not shared. For the purpose of we need to wait till we have the paper and then publish the data. And we realized that there was, case data collected that would have been useful for the response operation. And I think from that time, there was this call for, open data sharing during emergencies, that it made available for public health use, and waiting for the evidence to be published in a peer-reviewed journal. But what emerging from that time then is what we've seen now are the preprints. And that has been actually also a challenge to the response, because there was then suddenly too much information that didn't went through a peer review process that would make that was not vetted. But the way it was used by media, social media, is like preprints is quasi already the results of a research process, which was not. So you see, there's always this duality of what we're asking for to reflect on a challenge and then how we put that in practice. So a second thing to remember. To your question to me, so what is WHO doing about this? To reflect on these challenges we observe during the COVID-19 pandemic and go further in the future. I think first is that we organizationally have set up a new entity in the health emergency program called the Hub for Epidemic Intelligence, with the kind support of the government of Germany that is based in Berlin, but is fully part of the health emergency program, to really join efforts in all these elements around how we are collecting data, how they are talking to each other, how we will build sustainable systems for countries in the future to do drive and data-driven, science-driven process of how we use data for decision-making tools. And I think this is where we organizations have set up now an entity that really streamlines these efforts, but then looking forward in the future, how we build those tools, including modeling tools that are standardized, that are validated, and put to the test in some countries, and could be used by others. Because when we look really honestly, and also what Gabriel said, there are actually only a few countries that have a systematic science-driven approach and that have strong modeling groups that are integrated in the policy process. For many countries, they don't have that investment or can afford that investment yet to have this, and they really rely on best practices and standardization around this and advice from WHO. And I think this is what we're aiming at with the Berlin Hub, to really provide that platform for those member states in the future.
Great. Priya?
So maybe just one reflection on the data sharing piece, which is that right now, the way we operate, the way the world operates, there are some disincentives to sharing data in the wake of a crisis, right? Just flash back and think about, when South Africa reported Omicron, what was the backlash, right? So I think some kind of, here's really where sort of international cooperation, mutual understanding, a shared understanding of what happens, how a country that's willing to share its data in the course of in the early stages of an outbreak, how it would be treated by the world, right? And I think here I have a lot of hopes on the pandemic treaty or the pandemic accord that's currently being negotiated by the intergovernmental negotiating body amongst WHO member states, and let's see what comes out there, because I think that would be really a shared understanding of how I as a country will be treated if I do take that step and share my data and tell the world that there's this virus in my country, and that's kind of has the potential to spread around the world. So kind of that's something that's, I think, not yet fully worked out, but it is at least on the table. And to your question, what are we doing? So I think at the World Bank, we've learned a lot from COVID, but also in the past from all the other outbreaks that Gabriel mentioned in his opening. But I think one thing that's really become quite clear now is that, as I mentioned earlier, we cannot fall into that cycle of neglect. So right now, there's a lot of work ongoing at the World Bank. There's a global challenge program that's being put together on emergency outbreaks and the area of pandemic prevention, preparedness, response. How the World Bank can sort of work to step up its support to client countries. Of course, the Pandemic Fund is another kind of outcome of lessons learned from COVID-19. There's work to develop a playbook for countries on how to respond to the next outbreak. So, the attention is there. The momentum, though, needs to be kept in a world of polycrises, which is the theme of this conference. It's really easy to sort of quickly, divert attention to multiple other crises. But the work that's come out of COVID at the World Bank, I think, will help us as an institution keep our focus on on pandemic prevention and preparedness alongside other crises. And the interconnectedness of all these crises as well is something that, we constantly remind ourselves and remind the world.
Thank you. I'm going to allow the audience here to ask a question. And before you raise your hand, I'm going to ask one question and then I'll see which hand is raised and give you the chance. I think you have all mentioned the challenges and what your organizations are doing. And I want to pick on one. Thanks for mentioning about the pandemic treaty. To an extent, countries really respect, member countries for WHO really do respect word from WHO. And Mark was indicating that there's not many countries that have a process of getting like modeling insights, translating into policy. And I know there are attempts, for instance, with the immunization, where you have got national immunization technical advisory groups, which are really important when you're introducing new vaccines and all. Is there an attempt from WHO to propose to member states what that kind of advisory that comes from a crisis, during a crisis time, how that could actually be translated or used in policy making at the country level? I'll let you answer that question. And as you do it, I'll look out for any other hand. Go for it.
I think there's not only a attempt, but there's a whole process, on building that capacity in countries to really use science and knowledge and research into the policy-making process. I think this has been always done, in different structures, but actually, with Dr. Tedros coming into office in 2017, one of the first changes he did to the organization was to establish the science division and have a chief scientist around this to really, capture that element of introducing a scientific process into the decision-making process and really looking at the drivers in each country, to enable this. And let's be honest, science is an important point, but there are also other elements where decision makers need to take a decision on, also with the science or in the absence of the evidence. And I think that's a process, we all acknowledge, but we can ensure that there is a science-driven process in this. And there's a lot of initiative and capacity building ongoing in WHO to really build that capacity as part of the decision-making process. And I think there are actually several side events here at PMAC that are really looking at, this evidence-informed process and how to establish this. And I think this goes back 20 years in WHO to really build, that health research element into decision-making.
Thank you. Yes, Alex.
So it's actually not so much a question as more as a comment on data quality. I find this really strange because there's standards for data quality from medical data, OMOP, for example. And I don't understand why it would be that in public health or in emerging infectious diseases, we're not able to replicate the same kinds of standards to allow for the kind of interoperability between systems and between countries. So I think that's something that I would really wish that kind of globally we're able to move towards kind of common data standards rather than not necessarily the Excel sheets floating about and so on.
Thank you, Alex. That was a nice comment. Unless one of you wants to agree with the comment. Anyone else? Okay, now that, yes, one hand there.
Thank you. So the conversation about capacity building has been going on, and it's definitely something that is essential for every country to do. But I would like to hear everyone's reflection, especially for countries with a very low resource setting. Capacity building takes time. So, and one of the panelists also mentioned about the importance of, actually there's a group of modelers that's available, but they've never done something in public health. So about networks of researchers, like, is there anything that perhaps this commission is looking forward to give some kind of like recommendations towards like how to build networks with the researchers for those who are working in public health and in public health settings? Thank you.
The commission.
Yeah. I think we definitely in the commission we've very quickly identified this as an important question. In fact, even if we identified it, but all the stakeholders we talked to pushed it on us as well. I think I remember especially we talked to Dr. Justice Novinon from Africa CDC, and he said, I don't care what report the commission puts out. What matters is what happens after the commission report is put out. Will this continue to, bring capacity strengthening to different parts of the world? And actually, that is very much in our hearts. But how we're going to do this, I think we need really input from everyone. I think one thing we do recognize is maybe not every country will say we're going to set up 10 modeling groups if the population of the country is only 5 million people or something. And maybe there needs to be sort of regional and even global collaboration where maybe regionally there could be, regional hubs which don't just belong to one country, but, belong to regional organizations and say, actually, can we support countries as, crises happen? Can there be modelers who are not just belonging to one country, but actually able to pool resources and even pool models, but at the same time be very locally driven so that they won't just come out with conclusions that no country recognizes, but actually work very closely with individual countries. But I'd like to hear from everyone else.
Maybe just to add on this and the last comment you made, I think we heard from Gabriel, the history of mathematical modeling in epidemiology, and has been evolution since 20, 30 years. And he explained the beginning, and actually when we've seen this 20-year evolution, lots has happening around really bringing mathematical modeling into a higher profile into public health. And I think that's thanks to those initiatives and individuals that have started this and taking this on. So I think first take stock that it has evolved over 20 years and has become stronger than the traditional countries that have put a strong effort into this. So this community has grown and has, let's say, exported this knowledge also in other countries. I think in Kenya, the mathematical modeling team you leading did not exist 30 years ago. So it's part of this movement that is integrating. Second, and he only said it in one sentence, but it's so important, how to, at the national level, socialize this into the decision-making process. And basically what Gabriel was saying is you need to build that connection to the decision makers from the academic side, once you have that and nurture this relationship, this is, the integration of that process into the policy-making process. And this is a skill, I think, those academics needs to bring into understanding the needs of policymakers and how to frame it that this approach that is useful to the policymakers. And this is just not happening because you have a great model, but it's just really that process of science and communication that is needed from academia nowadays to really integrate and understand the decision and policymaking process. And I think having this is that one success factor in every country, in every setting, even in low and middle income countries. If you have at least those people that understand and how to integrate into the policymaking process, I think that's the key to drive this and build this science-driven approach into decision making.
Well, surprisingly, 30 minutes are over. It was that fast. But I will allow the panelists to make one final comment. And as you make your final comment, I want you to tell us, as the modeling community, what we must urgently address. And that, I think, should be part of the Lancet Commission. Yeah. So let's start here.
Let me starting on Gates Foundation is one of the largest philanthropies in this year. The budget we just announced is $8.6 billion US dollars. So it's a big money, you think. But in terms of capacity, all science, all take resources. And, I realize, like working in this foundation, I see all the competition between the different priorities. We're talking the poly crisis, on how to, I think for this community, I only have one suggestion, which is, be smart in your value proposition about, why this matter and why it matter and what's the consequences if you don't have it. I think it's almost the same question, why it matter. And connecting to the policy making, make it, I think, Tim, the interest in epidemiological modeling is go up on the upper trend. But it's, it's a facts and feast and famines over time. We just after a pandemic, I think a lot of interest, if I can predict the future, I think that may be a challenge that people, especially like they turn attention away from modeling. So, I think now is a good time to work harder and also maintain that interest.
Thank you. Priya?
So I absolutely endorse everything that's just been said. I think one key message, and it's come out more broadly in the conversation this morning, is the power of partnerships. And for your particular Lancet Commission, the partnership that this will hopefully help create between the modeling community and the policy-making community, because unless those two speak to each other, then, as you were mentioning, Tim, the best of modeling won't really find its way into design of policy intervention. And, that presumably is, the reason why this commission was set up, and the benefits of whatever comes out really can only be reaped if it's taken seriously by the policymaking community to design, to prioritize and inform interventions. So I would really encourage that partnership to be forged strongly as you develop your work, not just once you come up with your findings, but while you're developing, which I'm sure you're doing. But it's even kind of the importance of that can't be understated. So.
Thank you.
To build on these two things, what we often see during peacetime, there is competition among modeling groups, right? Which model is better? The competition about limited resources, into my research. So there is competition, and we acknowledge this because this also advances research. But during the pandemic, what we've seen is that these groups came together and work in partnership, because during the pandemic, science itself was under attack and was challenged. And, in this time, we've seen these groups coming together and supporting the response. And I think that's where the Commission needs to build and forge that partnership among these partners to advance this field. I think this is where I think you can have a lot of gains with the Commission in really bringing those groups together to discuss and what we do together in terms of advancing this field.
Mark, final words?
Nothing to add, just that I want to thank everyone for their wisdom, and this is definitely things that we want to take into account as we develop the themes of the Commission. That's why we've asked for permission to record all these sessions, because we really want to take this into account as we develop our recommendations. Thank you so much for this.
Thank you.
So thank you, Professor Thumbi, and our panelists for do hold on to your microphones, because we are not done yet. We have heard an exciting and rich set of experiences and some lessons from the past. But now we also want to know, what can we do going forward? So for those of you who still have questions, you have an opportunity to ask some more of our esteemed panelists and some more members who will also join. Because really, it would be nice to have some kind of a crystal ball, right? Like the one that we use in the Lord of the Rings. Anyone here knows Lord of the Rings? Okay. What do you think, Chayapat?
Yeah, you mean something like crystal ball from the Little Mermaid?
Sure. We speak to all generations. So with that, we'd like to invite Serene Casey to help moderate the next part and help us look into the future and bring our esteemed panelists into the final part of our session. So Serene Casey from HITAP, please welcome him.
Thank you, Saudamini and Chayapat, for letting me host this panel discussion with these experts here. But before we go into the future, I would like to welcome our fortune teller, Associate Professor Wanrudi Isaranuachai from HITAP. Please take a seat. Okay, thank you. A really exciting discussion. Thanks to all, and Prof, you really led the discussion going from history, now thinking about the future. So the seats that you're sitting on is no longer a seat. It's a time capsule, and we are being exported into the future in 2030. So that's where we're going. And WHO is calling upon us to look at disease X, which is becoming a fancy word. And they're looking on you to come up with solutions after looking at the issues that we've been discussing, right? So to align with the theme of this year's PMAC conference, which is geopolitics, I would like to open this panel discussion asking Priya Basu, what do you think, how do you think geopolitics is going to shape in the next 10 years? Having been in the time capsule, what do you see into the future?
No, thank you for that. So it's 2030, and there's a disease X that's spreading, but the pandemic fund has met all its objectives. It's managed to raise that $10 billion per year from now till 2030. It's managed to incentivize countries themselves to make those $20 billion per year investments in pandemic prevention, preparedness, and response. So, you know, the promise has been achieved. And so the minute that disease X, began to originate, it was quickly detected. There was a 717 indicator that had already kind of come into play. So in 7 days, it was detected. In 1 day, it was reported. In 7 days, it was contained. And so, the world was protected. Millions of lives, trillions of dollars were saved, and the outbreak never became a pandemic. That's my 2030 time capsule hypothesis. And of course, in the process, you asked about geopolitics. So, the success that we got to at 2030 was very much a product of the world recognizing that it is very important to invest in pandemic prevention, preparedness, and response. Amidst multiple crises, human health security is economic security. Health security is global security. And so the international community put, a priority on this agenda. And that is why, we at the Pandemic Fund were successful. We were able to work with our partners and, make sure the world was equipped to deal with this kind of an outbreak. So.
Thank you. Very rosy future indeed. And hopefully that does come true. But now I bring you back to present. We remove the time capsule and maybe go to Tim. Looking at that future where everything is rosy, everything we've managed to accomplish, but standing from where we are today, especially talking about geopolitics where national interests tend to take over regional or global interests, right? And there's also power dynamics between countries and regions. What challenges do you see for us to get to where we want to be in the picture that Priya just painted?
Well, to be in the picture that Priya, you painted nicely, I think we need the pandemic treaty. And we have crunch time at the moment. So at the next World Health Assembly, this May in 2024, hopefully the 194 member states of WHO have negotiated and finalized a pandemic accord or treaty, as it's being called at the moment, to really have a rule-based approach. How we as a global community come together to support and share information, data, tools, including vaccine treatment and diagnostics and other medical countermeasures, really on an equitable basis. And these elements are being discussed at the moment, through an INB, an intergovernmental negotiation body process. Among these are 194 countries. Basically, what you see there is not individual country holding position, but groups of countries. And for different articles, there are different grouping. I think today we heard, the division about global north and global south. I think it's more granular than just north and south. But there are grouping of countries who hold different positions. And basically, the ask is, to change the status quo. So we cannot have something again that we
had, at the beginning of the pandemic, but we need to have something better. So how do we adapt the status quo that we are better prepared as a global community in the next pandemic? And that's at the core of the negotiation and the pandemic treaty. And I think this is still time for countries to come to a consensus. So this next month in February, there's a 2-week negotiation process in Geneva, and also in March, another 2 weeks where really countries need to come together and agree on the different articles and pain points that are still there, to overcome. And one of them is around, access benefit sharing. So really that we have, a solution in terms of sharing something and getting something back. And I think that's at the heart at the moment of the different points that need to be agreed upon. Can we get there? I'm optimistic we can get there because we have done it before. We have done the pandemic influenza preparedness framework that specifically just for pandemic influenza came to an agreement among 194 countries, how we are sharing, viruses in return to benefits from the system. That includes all member states plus the private sector, including in this process of coming to that agreement. We've done it before, and I'm hopeful that countries can come together for the pandemic treaty and have a solution in May 24.
Thank you, Tim, for a very extensive brief on what the pandemic treaty can do for us to get to the picture what Priya painted. Just to follow up, do you expect the role of WHO changing with this new pandemic treaty? And if so, how will that change take place?
Okay, I think it's first to clarify what is WHO when you're talking about. First, WHO is the 194 member states that need to come together. I am a staff member of the WHO Secretariat, so I serve the 194 countries. So first of all, when you come to the change is that the member states agree on a rule-based approach. And I think that's the biggest change, that there's a positive agreement among these countries to agree on a playbook in terms of how they want to deal, with these big issues that were undealt with. And it will then support the Secretariat to execute these rules. So it will just strengthen for us, to have a rule-based approach. If we won't have a pandemic treaty, the work still needs to be done. So the Secretariat has a fallback mandate always to protect health and well-being of people. And I think there is that technical level that the Secretariat need to execute in terms of pandemic preparedness. And we have different resolutions that enable us to do. But the pandemic treaty will enhance those resolutions and enable us to work better in this. So the big change is really coming in terms of that the countries have agreed on a rule-based approach to help us as the Secretary to execute this.
Thank you, Tim. Turning my time capsule towards Fuji, talking about geopolitics and pandemic treaty, there are two supergiants, China and US. Do you foresee, or do you see into the future these two giants coming together and making this pandemic treaty happen?
I definitely hope so, and I wish Tim you the best of luck in writing to the final destination when the treaty is signed. I think the geopolitics and the poly-crisis are, there's solutions, I will say, or starting somewhere. I don't, may not be a solution that immediately clear, but I think we can starting somewhere. One of the place that we can starting is go back to Priya's point, is the pandemic fund. You said a 10 billion. Oh, okay, 10 billion. I don't know how much you have in your pocket now.
2 billion.
Oh, okay. So 80% is still missing, right? So I think that's kind of something that we can put our heads together and I think what is the way getting the 80% that is not even half fill for this bottle. I have some. I don't have. It's not my original idea, but I saw a program yesterday in our book. A program book is testing the bad for the good. It's not necessarily bad, but I think about which countries suffer more when during COVID told us that the rich country that lost trillions and trillions. It's not the poor countries. I mean they have a limited ability to pay anyway. So if you want to say we raise the billions to pay, to avoid the penalty of eventually trillions,
And who's going to pay the billions now on tomorrow? I think the rich countries should think about this. They are in a position to pay, China and US, and those, economic powers, and how to realize that. If you call the president, I think they may not give you the answer. And I think about creative ways to getting the billions. One of the suggestions, testing the bad for the good, is taxing the airline industry. They are one of the major polluters anyway. If you sell tickets, I think we in the U.S. already taxing the gas for the roads or whatever. So I think those kind of one of the many ideas. So we're creating a kind of a stream to pull, instead of raising the fund, replenishment every 5 years or whatever, every other year. And it's a possibility we can have go industrializing this fundraising. So I just idea. I mean, again, I think we should be together thinking about the realistic solutions that are getting the 8 billion that's still going to the pandemic fund. And I think as a scientist, I always feel like, there's going to be a solution. So the world can be protected. If we invest, the tools will be available. And the capacity will be built. So I think that the resources can be mobilized.
Maybe Mark, would you like to reflect on these discussions?
This has been really interesting and sobering, and I think, Priya, you've really helped us understand the stakes, understand how important this could be in terms of saving. Within 14 days we can save trillions of dollars, millions of lives. I mean, I couldn't help but think the opposite vision, the dark vision, if we don't get this right, is emerging infection happens in 2030. The country that detects it decides not to announce it till many months later because they're afraid of the backlash. Country Y decides they are very rich, but they don't want to put any money in this because they'll just close their borders when it happens. Country Z develops a vaccine very quickly, but quickly buys over all the doses so no one else has any. And then country A is too deep in internal conflict and war that the virus spreads throughout the whole country and they can't do anything about it. It becomes a place to spread to the rest of the world. That is the dark vision of, if we don't get this right, what could happen.
Dr. Wanruji?
So thank you. Perhaps go back to Sarin's first point, and follow up on Dr. Priya. Very nice future. I have a feeling that it could happen. Perhaps we can also add one more thing, that by 2030, then all the recommendations from this Lancet Commission will be followed. Yeah. Modelers and decision makers walk hand in hand. And come to Thailand for good food. So that would be nice. Now, since the last discussion, there was a lot of discussion about data part. So it's kind of make me also think that at least one of our recommendations need to really focus about the data sharing part in a way. But again, like my question is, it will be about the data part in the future. But at the same time, it may apply to a lot more than that. Like the simple question can be, does it need to be all or nothing? Because putting a whole treaty together, there's so many parts, right? And I'm sure WHO has seen so many situations where not all member states agree on things, and some things still need to move forward. With the modeler hat on, I mean, how often can we say the model that we have get all the data we want? We never do. So when we think about this data sharing part, does it need to be all or nothing, in the future? And what would that look like to us? Because sure, it would be great that, we can get all the data, all the information shared. But a lot of the data that modeler we are talking about, we don't need biological sample, for example. And those are the key ones. I'm not saying it's not important, but for the modeling part, we may not. So it can start off something as simpler. So could that be something that we all consider that it doesn't even some is better than nothing. Yeah.
Incremental approach. I like that. Prof. Thumbi, would you want to reflect on any of these points?
Yeah, sure. Whatever came to mind was we have excellent effort at the global level, and we end up with great documents and even funding. The part I would worry for is that not cascading to the country level and eventually to the communities. I think the responses to any pandemic or to any threat to humanity requires the people. People have to say, I agree to isolation, I agree to quarantine, I agree to taking a vaccine. Yet that, in my mind, appears to be one of the biggest challenges that we might face in the future. Because one, as we say, there's a lot of misinformation, but maybe even the issue is that there is even less real information. Like the people that can provide the real information are not willing to put themselves forward and be a voice in the public. I do see that as a potential challenge, that we have solutions that can be available to humanity, yet the humanity is not picking them up because there are all these issues where communities were involved, how much they trust their politicians or how much they trust their scientists, and maybe that's an opportunity, in my view, to not only deal with the global component, but also think about the community and how to engage with them.
I must fully agree, what Thumbi just said, and I think we heard it from Vivian from as well. I don't know if she's still on. It's really, how we bring that sociological part into this work about modeling. I think this is something, overlooked, in the past, of really understanding population questions, concerns, and how we bring in also behavior into the modeling in terms of increasing acceptance of any, vaccine treatment, but also on public health and social measures, and really understanding the sociological part of communities there to bring into the equation around modeling. And I think that's something that the Commission, must look at and really also provide solutions in the future. How do we integrate this in our decision aid model of better understanding really community level and acceptance of the decisions that we are recommending? And I think if we're not making this as part, and this was my lessons learned with my talk, is really bring communities into the decision-making process and making them a part of the solution and not talking only about them without them.
That's a great point. I'll come to Mark and Wanruthi about how models can incorporate or bring community as well as the issue of public trust, right, into models. But I feel like Priya has something to share, so please go ahead.
Thank you. No, I just wanted to really echo what you said about thinking about this in terms of countries themselves and within countries, communities. And I just want to make the point that this 10 billion that I'm talking about, what is it for? It is really, in that vision that I put forward in the beginning, it's really about making sure that every country, every low and middle income country has the institutions, the systems and the services to be able to deliver in the face of any emerging outbreak. So that's where we want to make the investments. We want to make sure that communities are engaged and that there's trust between people and government. So, that is very much sort of part and parcel of a success, the success vision. But even if that success is not achieved, in terms of stopping a pandemic, stopping an outbreak from becoming a pandemic. So maybe, in my vision, it was in 7 days, it's detected and then it's reported and it's contained, right? But say it's not detected in 7 days. If you have the systems, if you have the services, if you have the institutions, if every country around the world has a national CDC, if every country around the world has that trust between communities and governments, then you will be able to, prevent at some level that outbreak from becoming as vicious as COVID-19 was. So it's all a question of degrees, right? But unless you have the basis at the country level, so yes, it's easy to sit and talk about global accords and global funds and global institutions, but ultimately all of these are to serve communities. So that's the point I just wanted to underscore.
Thank you, Priya. Before we go back to, any questions from the floor?
Okay, thank you. I have two questions to the panel. The first is, I think you make a very great idea of what should look like in the next 10 years if we fulfill the requirement of the pandemic funds and the WHO also achieve the pandemic treaty. However, as we need to live in the future and a lot of uncertainties. So what would have happened if we not get what we want for the pandemic fund, I mean, in terms of the budget requirement, and we are not going to have the endorsement of the pandemic treaties in the next 10 years. So I ask should be the priorities? What is the top priority for the pandemic fund that we want to do from now to prepare for the pandemic in the next 10 years? So you cannot do everything that you plan to do, but what is the most important thing for the pandemic fund that you think that we should do? For the WHO, the same. What is to be the top priority for the WHO to implement? If you don't have the treaties that you like the most, what is the second most that you think that we can do? For countries and even for the modelers to what we should advise the country to prepare if we cannot rely on pandemic fund and the WHO treaty anymore. Second question is, I think one thing is that compared to SARS and H1N1, at that time it's very rare that in the world that we have one individual that can communicate millions of people at the same time, and everyone can do this. So when we see that in COVID, this is the first time that we face the pandemic when everyone have power to communicate to anyone around the world, and that's why we're facing a big problem about misinformation. So I wonder to see, because in the next 10-year time, I don't know how far it goes, maybe. Even not single individual people, maybe AI can generate information themselves, I don't know. But so I'm asking, especially for the mode, I want to ask the VHOs, the pandemic fund, do you have any plan to deal with misinformation? But I want to ask the modeler too, because I think the modeling perhaps can address, but at the same time can be cause of misinformation too. So what is, as the modelers, you are planning to address as part of the Lancet Commissions on dealing or addressing the problem of misinformation if we have the pandemic in the next 10 years? Thank you.
Thank you, Dr. Yod, for these great questions. I'll turn it over to Priya first and Tim about prioritizing.
No, so thank you. Those are really excellent questions. And the Pandemic Fund, of course, is informed in terms of its priorities by the expertise that we have around our board. We also have a technical advisory panel that's actually chaired by the WHO. And, in setting priorities, we've really, taken into account the advice that we've received from experts. And what are the experts telling us? The experts are telling us that there are three most important things. I mean, there are a lot of things that one can do, but you've got to prioritize. And those priorities have been reflected in our first 2 rounds of funding. And those are focusing on early warning systems, focusing on surveillance, on laboratories, and health workforce. And by health workforce, I mean everyone that's involved, from community level workers, frontline workers, to doctors, to nurses, to field epidemiologists, to lab technicians, the workforce, human resources. So that's what we focused on. So that's kind of, that is, if one can get that capacity built at the country level, but also across countries, because as we've been saying, a lot of shared, data sharing is very important. Laboratories that can collect samples and transport them, to regional networks, regional to global. So, these priority areas at local, subnational, national, regional, and global. So that's kind of the focus. And the other is actually very explicitly the role of kind of in both designing the projects and in delivering them, the role of civil society and communities, So that is kind of the narrative around the priorities of the pandemic fund. But going forward, we have other areas that we would also like to support. For example, pre-positioned access to vaccines and other medical countermeasures, so that at day zero, you can get access. So that's something that right now we aren't investing in, but it's part of our scope.
Thank you, Priya. Tim?
No, thank you. So you have basically two questions. The first one is, what do we do without a pandemic treaty? And the second one is, how do we deal with misinformation in the future? So on the first one, what do we do without a pandemic treaty? Actually, we have 300 recommendations coming out of the COVID-19 pandemic. This has been systematically collected, and the WHO Director General, Dr. Tedros, he actually made 10 recommendations, based on the collection, what we could do. And, coming out of this, WHO has already identified what we call the health emergency preparedness and response architecture. So some of the capabilities and capacities that we need to strengthen in the future to be better prepared for emergencies and pandemic. And this is around, 5 critical areas that we must strengthen. This is collaborative surveillance, community protection, safe and scalable care, access to countermeasures, and emergency coordination. So we already have established that system of lessons learned where we need to integrate and increase this capacity at global, regional, and country level. So we have a plan in terms of sustaining the investment, what we have done for COVID-19, and how we prepare ourselves for the next pandemic. And this is something, that we do and have done in parallel in terms of really looking at those operation capacities that need strengthening, so we are better prepared for the next pandemic. A pandemic treaty would enable to do this better, in context of really finances, in the context of really sharing resources, at the global level in an equitable way. So the pandemic treaty is about really, changing that equity lens and be better in terms of, sharing these resources at global level. In the absence of a pandemic treaty, with the COVID-19, the world came together. They established the ACT as a system that did not exist before, but around, we need to accelerate, the sharing and access also to all countries into these countermeasures. Was ACT perfect? Not necessarily, but it was that instrument that had to create it ad hoc in the absence of a pandemic treaty. And I think they did the best of their job as possible without that rule-based approach. So we don't want to go into a system where we have to recreate everything again during a pandemic where they're working together. But the pandemic treaty will already enable us to prepare for this situation, that these elements are existing and that come together instead of losing time, in the emergence of a pandemic, that we need to come together and define those rules again. On your second element about what we're doing about misinformation, I think WHO was one of the first, to raise the alert about an infodemic, the overabundance of information, that impede, including mis and disinformation. And I think we created a whole scientific, advanced scientific elements around infodemic management, but also, define some of the key actions, that we need to do. This include building resilience against misinformation. Effectively, we will not be able to run every piece of misinformation out there. But if we build resilience in communities, understanding the mechanics around this, have a critical thinking about what they read and what is being shared, I think this is the kind of behavior change we need to go into the future to build that resilience into our communities, to understand the scientific process, to understand the mechanics of, what we're sharing on social media, to understand, about the interest of special groups of creating this. There's a lot of knowledge that are being generated through this science, and I think we need to build that socialization about how we deal with this kind of information on social media in the future. And I think this is where we have created that concept of infodemic management, and hopefully, I believe that this has that attention of member states at the moment, because it's not only a health issue, it's a political issue. You have this at around every political elections in the country and how to deal with this. So it's not only a health issue, but it crosses, different elements. And I think we can talk about climate change and so on and so forth. So we have this element about how people are interacting with information nowadays in our society.
Thank you, Tim. extensive response. Prof. Thumbi, may I just also ask you to comment on, from the modeler's perspective, how can you prevent or not be a contributing factor to misuse or misinformation during pandemics?
Thank you. I think what came to mind is a Swahili saying. It says, kidole kimoja hakiwezi vunja chawa, which means if you had lice in your hair, you can't use one finger to crush it. Sort of need more. So I do think part of what we need to do as the modeling community is to have many more people speaking the positive things and giving the right information. I do think, for instance, and it was said this morning, that AI is about what comes in and that's what you get out. So one part is that if you don't have enough good information out there, then our world will be ruled by the disinformation. So in a way, it's a call for all our fingers to get a hold of the lice and deal with it.
Thank you. Interesting analogy, Prof. Shall keep that in the stock. I want to throw back this question to the co-chairs of the commission on what you think this misinformation during pandemic means and whether the commission is trying to address this in any shape or form.
I think that's an excellent question. And I actually think the question on misinformation is very closely tied to some excellent comments my colleagues had about engaging with communities. I think this is very close together. And I think the pandemic, COVID, was a wake-up call for a lot of modelers because before 2020, some modelers still thought of themselves as basically we're mathematicians, we're analyzing some interesting scientific problem, which just accidentally happens to look like what's happening in the real world. But I think the COVID pandemic made all modelers realize, number one, we have a lot of influence in what happens in the world. But number two, we are seen as another actor in the whole political process, which both has influence but can be attacked and can be, on all levels, scientifically, personally, even physically in some circumstances. So it's a wake-up call for modelers, and I think that's why in the commission we've not just said we're going to deal with the technical aspects. Should you use model X or model Y? We said at the core of this, we want to talk about communication. We want to talk about engaging with policy, but it's also, I think, part of this will be thinking about what is the essential skill set training as modelers. And maybe going forward in the future, my feeling is, for my own PhD students or postdoc modelers, I need to tell them, you're not just here to apply your mathematics. You're here if you want to actually be able to, talk to policymakers, sit in a focus group with members of the community who might be skeptical about science and explain what you're doing, respond to a social media post which is trashing your work. Unless you're willing to do all these things, don't become an epidemiological modeler because you will have to do these things.
The last part is like personal experience, I'm assuming. Right. Just echoing the point that, I think in our Lancet Commission work, we do have, as Mark introduced earlier, a part, the working group focusing on the policy part, the technical part, which is being led by Professor Alex Cook, who's going to come up after this to give us all the answer that we need. No pressure. And the communication working group. So from the discussion and all the point, I think, not sure we have all the answer, but we're on the right track, at least, to addressing a lot of these points. And just really appreciate everybody's time and comments. So we'll certainly take it back. Yeah.
Thank you. On behalf of the commissioners, I'll let Alex summarize the key points, but maybe to the panelists here, if you have any final key words to our audience.
Well said, nothing to add.
No, just thank you very much. Great discussion.
It was a pleasure being here.
Hi, everyone. Hopefully you can hear me okay. So I have the task of trying to summarize 3 hours before lunch. So I stand between you and your food, so let me try to be as quick as I can. And I apologize, the very last session, because I was working out how I would be sharing, I may have missed some parts of that last discussion. So we started off with some storytelling by Gabriel. I felt that he gave some scene setting to begin with. He actually contradicted our title for the session by saying that modeling is not about crystal balling, but a method to test hypotheses quickly and safely. In his view, he's arguing that the Lancet Commission should be aiming to get people to appreciate what you can and you cannot do with modeling and to evaluate what is good work and to get decision makers to follow good modeling science. He also counseled that we shouldn't be preparing for the next pandemic by being preconditioned to think of it as being going to be just like COVID-19, because the next one will be different, maybe a flu virus, maybe Nipah, etc. He then spent most of his talk looking back at previous outbreaks and the role of modeling within those. So the HIV pandemic, which is of course still with us, was one of the sparks between that created one of the main reference books, a seminal work by Anderson and May. Then some of the other outbreaks he spoke about involved conflicting roles of modeling. In SARS, he showed that modeling could influence decisions. But he argued that the flu pandemic of 2009, actually models did not matter because by the time we realized the pandemic was upon us, it had already spread madly around the world. There was nothing we could do to put it back in the box. Coming forward to COVID-19, he argued that models did matter during COVID-19, but I think he caveated that with the argument that it really mattered in places that either had an imprinting of past outbreaks, and he mentioned Hong Kong, Singapore, didn't mention Thailand, but I think Thailand also had a very good response, or which had a science-driven approach to policy making. He also argued that a lot of countries that did have really good modeling capabilities, like the US and UK, had terrible responses because they were not following the science. Okay. We then had some sharing on the Lancet Commission by Mark and Ranrudy. The main points here were that modeling can save lives, but it is a cottage industry at present. It needs to mature and needs an environment which is conducive to that if it is to inform policy as effectively as possible. They speculated about what the likely recommendations will be, that we think that models to inform policy should follow some guidelines, that we need to nurture capabilities, and that there needs to be co-creation between the users and the developers of models. Okay. We then had storytelling from our panel, and so I've attempted to summarize each one of these. So Fujie said that it is effectively not how complex your model is, but it's what you do with it. So he gave the example of isolation, how an unpopular action can get can become palatable through the lens of modeling. That can be then a form of evidence that policymakers can use to go with something that they wouldn't have otherwise wanted to do. She also is a very keen proponent of early action. And again, modeling can tell you at the beginning of the outbreak as to what might happen if you do or you do not take a response, and therefore can be similarly can be useful in convincing policymakers to take their action as quick as possible. She argued that it is necessary to build capabilities, but she was stressing that perhaps not so much in modeling itself, but in the communication between modelers and policymakers. She suggested that we should, as modelers, act with humility, because although we may have the data, but we don't know everything, and we need to make sure that we have dialogues with the people who will actually be using those models. And that segues quite well into Tim's presentation. So he gave the example of the yellow fever rollout of vaccines to cover some gaps in our vaccine coverage in parts of Africa. So there, the modeling was identifying risk factors that could be used to say which parts should be prioritized. And it's relatively simple modeling, but which the key to making it work was the subsequent multi-stakeholder consensus building, getting everyone into the same room together for a couple of days, making sure that they understand what the modeling is doing, what it's telling us, and then giving them this opportunity to give counter suggestions beyond just the modeling. So a point that he raised, which I think I've learned about in my own experiences, is that you shouldn't be replacing the decision maker with models, but the models inform the decision making. But you shouldn't be taking away their prerogative to make the decisions, because that's what they're paid for. Then we learned about the importance of intersectional and intercultural work to promote the health of the people. I think this, in relation to modeling, would refer to bring different disciplines together to jointly work on solving problems. So Vivian argued that to prepare for future pandemics, it's important to look back at past outbreaks, like what Gabriel was speaking about, and to learn those lessons, but also to learn the stories from other cultures, from other countries, what worked in those settings, and how can you try to deploy that in yours. She also was repeatedly mentioned the idea of social justice, and that is important for public health systems in general, but in particular when it comes to modeling, I think it will become more important over the years ahead that we try to account for things like socioeconomic status, migrants, different effects of gender or sexual minorities on outbreaks. And so hopefully there are lessons for modeling from that. Then in the final one there, Priya was talking about the pandemic fund. She explained how its aim is to overcome the waxing and waning of interest in supporting financing after pandemics and in between pandemics, and to help get health systems ready, especially in low and middle income countries. So it has a lot of foci on important things like equity and inclusion, bringing together stakeholders from global north, global south, from different government departments and so on. But is currently in funding shortfall, and so it needs to get additional funding if it's to meet the target of 30 billion per year, 10 billion raised internationally, 20 billion raised domestically. Remember that, right? Okay. Okay, so the first of the panel discussions was kind of backward looking at the past. So some of the challenges that were raised that I think we'll take note of in doing the commission is to do with data quality, what we wish for versus what the reality is, how to break barriers into data sharing, the disincentives that may arise for data sharing if you then subsequently get punished, like the case of South Africa and the Omicron outbreak, and potentially the use of greater use of data standards like OMOP. There was the notion of horses for courses, so that some models are appropriate for some situations, and it would be important that people using models know whether the model is appropriate for the particular course that the horse is running on. That we need to work on better interoperability of systems for data movement between different decision making, and that we need to work on keeping investments going so that the engine remains warm. And in particular in the context of modeling, that would be the question posed is what would the equivalent of Gavi be if you move away from vaccine procurement towards modeling? What should that be? One issue that arose was that partnerships with and the processes for partnerships for modelers to policymakers was often created on the fly. That's something that we would want to work on between now and the next pandemic, and that we need to cultivate networks between modelers in different countries. Okay. The second panel discussion, thinking forward to 2030 and a disease of outbreak X, we saw two different visions. Happy, rosy vision in which the pandemic fund had been fully funded, it succeeded, and disease X was nipped in the bud. That the pandemic treaty had been signed and a rule-based system which would incentivize pro-global behavior had been implemented. Also, that all of the recommendations that the Lancet Commission are going to make were effected and followed, and that would include the issues on data sharing. However, we also heard that the perfect is the enemy of the good. We may have to settle for something that is not at the level of the pandemic treaty that we're hoping for, and the pandemic fund may not be fully funded. So what are the plans for this? Priorities have also been identified by both. So for the fund, you've identified the three top areas, and you're starting to fund those already. For the treaty, even if it doesn't happen, you've already identified what you want as a backup plan for that. We've also think that by 2030 that we'll have modeling will have advanced in its technology, so it'll be able to incorporate good sociological underpinnings and to make best use of the community. And at this point on misinformation, I started wondering about how to get Zoom on, so I kind of lost track of the conversation at that point. But we'll look at our minutes later and identify what the key messages from that were. Okay, and so the remaining message which came across is of the importance of Thai food. So I'll stop there and hand over. Let you get your Thai food.
Sure, so that we can come back. Thank you, Alex, for that very comprehensive summary of the entire session. So all of us were able to revisit the insightful and incisive points made by everyone. And you've really ignited our imagination in terms of the future, 717. We'll try to remember that. So before we close, we just like to invite our colleague to give a very short hint of another activity coming up in the future, very briefly. So maybe with the microphone. Yeah.
All right. Hello, everybody. Just very quickly, my name is Ryan, part of HITAP as well. So on behalf of HITAP, we're very privileged enough to work closely with the ISPH, International Society for Priorities in Health conference. I'm sure that Dr. Banrudi previously, she mentioned about a conference which the Lancet Commission will be actively involved in as well. So this is a conference we are hosting here in May 8 to 10 this year here in Bangkok. So we'll be looking into strategies for sustainable solutions, and this is focusing on health priority setting. I will be looking at various topics, including early HTA, priority setting, equity and efficacy, environment, as well as crisis prioritization. So this is just a promotion. If you're very much interested to come back again and enjoy some Thai food, please do come again. Registration will close in the end of March. You can scan here for more information. For easy access, it's priorities2024.com. As simple as that. Feel free to learn more from there. Feel free to visit and hope to see you there. Thank you. Back to the MC.
Thank you so much, Ryan. So now that we are close to the end, does everyone remember the questions we started with? Whether epidemiological modeling helped us in the past pandemic and whether it will help us the next time round. We had more of a mixed message on the board, you might see, for the future. But we really hope that this discussion today will make us more of a believer. And we hope you don't stop believing. And before we close, we really want to thank you all for staying with us right through the end. We hope this will be the start and continuation of conversations on this topic, which will remain important going forward as well. We'd like to take a group photo, so we'd just like to encourage everyone to come closer to the center, and you can sit in your seats. And we have a very talented photographer who will take a photo.